Welcome to this MCQ challenge on autonomic seizure in a child from Professor Mohammadi's teaching archives. In this presentation, we will focus on higher order clinical reasoning rather than simple recall. The aim is to recognize an important childhood epilepsy syndrome from a realistic clinical vignette, distinguish it from common mimics, and choose a safe and balanced management plan. This case is particularly useful because the first symptoms may look gastrointestinal or vasovagal, but the full sequence tells a different story. Next slide, please. A previously healthy 6-year-old boy develops pallor, nausea, fearfulness, and a repeated sense that he is going to vomit during a car journey. Over several minutes, he becomes progressively less responsive, and his head and eyes slowly deviate to the left. There are no convulsive movements, but the event is prolonged, followed by profuse vomiting, confusion, sleepiness, and gradual recovery over 1 to 2 hours. A very important clue is the history of previous nocturnal vomiting episodes associated with confusion. These episodes may have been missed because they were interpreted as simple waking from sleep or gastrointestinal upset. When we examine the whole sequence carefully, the pattern is much more suggestive of an autonomic seizure than of isolated vomiting or syncope. Next slide, please. The diagnostic reasoning begins by organizing the symptoms into a meaningful clinical pattern. The earliest signs are autonomic, pallor, nausea, vomiting, and fearfulness. These are followed by impaired awareness, which is more than simple faintness or tiredness. The slow forced deviation of the head and eyes provides a focal sign, and the prolonged duration with postictal confusion and sleepiness strongly supports an epileptic event. The key decision point is not to be distracted by vomiting alone. Vomiting is important, but in this case it must be interpreted together with altered responsiveness, focal eye deviation, prolonged recovery and recurrence during sleep. Next slide, please. The central clinical question is asking for the safest and most coherent diagnostic interpretation and management plan. The examiner is not only testing whether we can name the syndrome, the question also evaluates whether we can separate seizure semiology from plausible mimics, choose appropriate investigations, avoid unnecessary urgent imaging when the examination is normal, and provide a practical rescue plan for prolonged seizures. A strong answer must therefore integrate diagnosis, investigation, risk assessment, and family counselling. The best answer is Panayiotopoulos syndrome, a childhood autonomic epilepsy. This diagnosis explains the prominent pallor, nausea, vomiting, impaired awareness, prolonged seizure duration, head and eye deviation, and postictal sleepiness. The previous nocturnal vomiting episodes with confusion are especially important because they suggest earlier unrecognized autonomic seizures. The management plan should be balanced. An EEG is appropriate and posterior sharp waves can support the diagnosis, although a normal EEG would not exclude it. If the neurological examination remains normal, routine urgent neuroimaging is not mandatory. However, because these seizures can be prolonged, the family should receive clear rescue medication instructions and safety advice. Next slide, please. Now let us consider why the other options are less appropriate. Vasovagal syncope can cause pallor and transient unresponsiveness, but it is usually brief and does not typically cause prolonged forced eye deviation, followed by an extended postictal state. Gastroenteritis may explain vomiting, but it does not explain stereotyped impaired awareness and focal ocular deviation. A posterior fossa lesion is an important consideration, especially when nocturnal vomiting is reported. However, in a child with a typical autonomic seizure pattern and a normal neurological examination, immediate routine urgent imaging is not necessarily the best answer. Gastaut-type occipital epilepsy is also less likely because that syndrome is usually dominated by brief visual symptoms rather than prominent autonomic features. Next slide, please. The investigation strategy should be guided by clinical judgment. EEG can support the diagnosis, particularly when posterior or occipital sharp waves are seen. However, the EEG findings may be variable and some children may have a normal EEG. Recording sleep or obtaining a sleep-deprived EEG may improve the yield. Neuroimaging should not be reflexive in every typical case with a normal examination. At the same time, clinicians must remain alert to red flags. Persistent or progressive nocturnal vomiting, focal neurological deficits, papilledema, ataxia, persistent headache, or a deteriorating clinical course should increase concern for a structural lesion and prompt further evaluation. Next slide, please. Management should be calm, anticipatory, and family-centered. The first step is to explain the syndrome clearly. Vomiting can be part of the seizure, not necessarily a gastrointestinal illness. Parents should know what to observe, how to document the duration and features of future events, and when to seek emergency help. Because seizures in this syndrome may be prolonged, families should receive a clear rescue medication plan according to local practice. Chronic anti-seizure medication is not always required after rare events, but it may be considered when seizures are recurrent and prolonged. Safety advice should include protecting the child from injury, avoiding oral intake during impaired awareness, positioning the child safely, and monitoring the duration of the event. Next slide, please. The final message is that autonomic seizures in children may initially look like vomiting, pallor, fearfulness, or a gastrointestinal problem. Panayiotopoulos syndrome is often recognized from a careful history rather than from a single diagnostic test. The safest clinical approach balances diagnostic confidence with careful attention to red flags. In this case, the key is to recognize the full seizure pattern, use EEG as supportive evidence, avoid unnecessary urgent neuroimaging when the examination is normal, and provide the family with a clear rescue plan for prolonged events. Next slide, please. Thank you for watching this presentation from Professor Mohammadi's teaching archives. I hope this case has helped reinforce how careful clinical reasoning can transform an apparently confusing episode of vomiting and altered awareness into a coherent diagnosis and management plan.